Canada. I've been in practice for over 12 years. I like to set myself apart from other orthopedic surgeons in Arizona with my academic background. I have over 300 publications. I'm a professor of orthopedic surgery. My work's won the highest awards from the Arthroscopy Association in North America and the Royal College of Surgeons. I have two main office locations. One's in Central Phoenix and the other is North Scottsdale. We're going to get right into it. So today's focus is on kind of general sports medicine. I'm going to talk a bit about the kind of stuff I see in my practice, but one of the particular areas we're going to be discussing today is cartilage injuries. So here's an example of a case I had recently. I think she's 16. She dislocated her patella. You can see that she's got a lot of lateral subluxation there on that axial. I know how well it projects, but you can probably see she's got really nice cartilage here on the lateral facet, but the medial facet cartilage is completely missing. So she has an acute osteochondral fracture of that patella in the setting of patella instability. So what would you guys expect to see here in terms of how we're going to deal with her cartilage injury? Obviously, we're going to do an MPFL reconstruction and stabilize her patella, but what are we going to do about the cartilage injury? No pressure. So that's a good suggestion, but if we look at her MRI here, you can see that actually that chunk of cartilage is loose in the knee. So if we were to leave it there, it's going to cause loose body symptoms. And also, the main point of this slide that I wanted to get across is actually the best cartilage procedure we have is to actually save your own cartilage if we have that option. It's far superior to any of the other cartilage repair type procedures. So in a young person with an acute osteochondral fracture, we can often make an attempt to save these. The longer the duration of time from the injury, the less likely we are to be able to fix it back. I think I got to this one at about 5 or 6 days after the injury, and already you have plastic deformation from the time of the fracture. The bone's doesn't fit perfectly, but then this thing's been floating around inside the knee and it's being a little squashed every time the joint's loaded. So it doesn't fit perfectly, so we have to kind of make it fit. So here's the arthroscopic images. So this is that medial facet of the patella, and you can see that there's a complete fracture there with cartilage missing. And this is the loose fragment in the knee. And then what we did was we fished that out arthroscopically. We do our MPFL reconstruction, but then we actually open the knee up to fix this back. You can't really fix it back arthroscopically. Some of these osteochondral fractures you can, but when it's behind the patella, it's kind of an awkward spot to get to. So we actually do a midline incision, evert the patella, and you can see that this is how it looks now. We fixed it back with a little screw there. So when we're talking about cartilage procedures, there's some prerequisites for that. One is that they have to have a normal or corrected alignment, which I'm going to show you some examples of in a moment. Normal or corrected joint stability, so that's the example of the case we just had. We're not going to fix that fragment back without doing the MPFL because she's going to have a persistently unstable patella, and it's going to just stress that fragment, and the fixation's not going to work. So we've got to correct these things. And then there's the obvious contraindications, you know, advanced arthritis, infection, inflammatory joint disease. Not an exhaustive list, but just to give you an idea. So this is what we mean by having a normal alignment. So alignment can mean different things in different pathologies and areas of the knee. So this is an example on the left-hand side of a patient who I did a MACI procedure in who has patella alta. Now that's in association with a little bit of maltracking as well. Usually they go hand in hand. You'll have all seen patella alta patients, so I don't really need to tell you too much about that. But obviously when the patella sits high, it doesn't engage the groove till later on, so they have a tendency to lateral tracking. It's often associated with an increased TTTG, so they have multiple factors usually. So in this particular patient, at the time of MACI, we also did a tibial tuberosity transfer to correct those things. So we distalized the tibial tuberosity and we also anteromedialized it to normalize knee, normal patellofemoral kinematics and improve her tracking. Otherwise, cartilage procedure is not going to work. Similarly, we can have malalignment in other planes. So this is something that we all see commonly as well. So this is varus malalignment. And in this situation, if we're going to do something on the medial femoral condyle in terms of a cartilage repair procedure, we need to correct that. Otherwise, it's not going to have any longevity to it. It might work for a short time, but it's going to wear out. So in this patient, we did a high tibial osteotomy. So here's another case example. This is also another young patient, but this time I didn't get to them until I think it was 18 months or so after their injury they came to see me. So they also had an acute osteochondral fracture at the time of their original injury, but by the time they saw me, they had a history of recurrent patellar instability and this old fracture. They did have a loose body in the knee. We took it out, but it was all misshapen. There was no way it was going to fit back. It was like a hard lump. There was no cartilage left on there. So in this situation, we have to do something else. We can't fix it back. And so we did an osteochondral allograft, and this is a particular one that's it's nice for the patella. One of the challenges on the patella is the shape. So you've probably seen lots of osteochondral allografts on the femoral condyles where it's quite easy to match the shape. But obviously the patella and the trochlear are kind of a bit more complex geometry, and to match them is difficult. But this particular osteochondral allograft is a very thin piece, and it's quite easy to actually contour into shape. So that was a good option for them. So there's lots of different types of cartilage repair procedure, but I'm going to compare the main two in this slide, MACI versus osteochondral allograft. So one of the downsides of MACI, which we're going to be talking about a little bit more, is that it's a two-stage procedure. We have to take a biopsy first. However, it's not that much of a downside, because I would say that the vast majority of patients where I'm doing a cartilage repair procedure, we do an initial staging scope anyway, because MRI is not that accurate. MRI is good at telling us where there's a full thickness defect, but it's not good at telling us about what's happening at the edge of that defect. And often when we get in there, we find that it's much bigger full thickness defect than is suggested by the MRI. So a staging scope is kind of mandatory in most patients, I would say. And so having an additional surgical stage is not necessarily that much of a big deal, but it can be an issue in some cases. The other thing about MACI is that it's really only a treatment for cartilage. So if you have an osseous defect as well, there are some situations where you can do some special tricks with MACI, or you can put some bone graft in there, but really it's primarily to repair the cartilage, not to repair a bone defect. So if they have a big subchondral cyst, you're probably going to be better off with an osteochondral allograft, which is going to deal with that bony defect too. We already mentioned one of the advantages of MACI, particularly on the patella and the trochlear, where the contour is quite difficult to match. You can imagine if we're taking an osteochondral allograft, if you've ever seen the surgery, even for a condyle defect, it takes quite a little bit of work to really match it nicely and get it to fit flush. And with the trochlear and patella, it's even more difficult. And so MACI has a big advantage, and you'll see that it's really just a membrane that we lay on. And I've got some examples of patella cases coming up. And it's very easy to do from a technical perspective, whereas an osteochondral allograft in those areas is actually quite challenging. Both of these procedures are rehab intensive. They're both expensive. They both have reoperation risks. However, MACI has a good advantage in the sense that although there is a risk of failure, when a failure occurs, it's not necessarily a bridge burning procedure. What I mean by that is that if you have a large osteochondral allograft that fails, that can be catastrophic for the knee. The bigger the osteochondral allograft, the more chances are that it's not going to integrate and heal. And if a big osteochondral allograft fails, that might mean that the next step for that patient is a unicompartmental knee replacement. Whereas with a MACI, because it's not bridge burning, you could do a revision MACI, you could do an osteochondral allograft, so you've got more options. When complications arise, they're typically less serious. Also, in terms of availability, osteochondral allograft is very easy to obtain. MACI is also very easy to obtain. It just requires that prior surgery to take a biopsy. So here are the steps in the MACI treatment. MACI stands for matrix autologous chondrocyte implantation, if I didn't mention that before. So step one is we take that biopsy. You can see that picture down here. This is how we take the biopsy. You can take it from different parts of the knee, but this is actually my preferred area. So that's a view of the notch. And right on the edge of the notch where the articular cartilage starts, that's non-weight bearing. It's not important. We can remove it. So we've got lots of good cartilage there that we can remove to take a biopsy. The biopsy's got to be from good cartilage. We can't take it from arthritic cartilage or damaged cartilage because we need good viable chondrocytes to culture. So then that gets sent off to the lab where they culture it. It typically takes about 6 weeks. They grow and expand. So in the sample we send them, there's X number of chondrocytes, but they expand them and grow them through tissue culture cycles. And they then implant those cells at the time of preparing for surgery onto a membrane, which is derived from pigs. And then we get that as this membrane that you see here. It's just a thin sheet of membrane with all the important cells loaded onto it. And then we implant it. And this is kind of one of the examples of that. So here you can see that this patient has a full thickness defect. You can see that there's some cartilage there, but if we were to put a probe in there arthroscopically, you would see that it's down to bone. It's just that in this situation where it's open, the flaps of cartilage are kind of overlying the defect, but it's a full thickness defect. Now, the first picture here is what it looked like when we first get into the knee, and this is the preparation of the defect. And you might think that that looks like a very large area compared to this, but actually what we need to do is we need to take that defect back to healthy cartilage. There's no point doing half of a job and leaving some cartilage in there that's not that great, because then we're going to have poor quality cartilage next to our new cartilage, and we need good quality cartilage next to it to provide support to it. So this is what it looks like. So we get that membrane I showed you earlier on, and then we just basically use a cutting block. So you can see one example of a cutting block here. Here's another one. It's basically like a cookie cutter. And we pick the most appropriate size for the defect. Sometimes we can't use these, and we have to custom make a cut in the cartilage using basically a scalpel. But whenever we can use these, it's very helpful because it's pre-shaped. And because it's pre-shaped, it means we can simply punch a hole in the cartilage to create our defect, and also into the membrane to create something that precisely matches that. Whereas when we have to freehand it, it's obviously a bit more challenging. So this is the same defect, and this is the MACI actually implanted into there. The steps of the implantation are, firstly, we remove all the non-viable cartilage, which you saw in the previous step. It leaves a big hole. Then we place fibrin glue in the base of that defect, which is what holds this graft in place. We put the graft in there, and then we put fibrin glue around the edges. And when you look at that, you're probably thinking, well, you know, there's still a hole there, right? There's a defect, it's recessed, and so that's absolutely right. And what happens is, over the next few weeks to months, well, actually starting immediately after we end the surgery, the chondrocytes migrate from the patch up into the fibrin layer that we've used to glue it. And during that process, they start to mature and create new tissue. And over the course of several months, you see that that defect fills in. Sometimes we can actually have the opposite problem of too much growth, and we have to go back in and smooth it out. But generally speaking, these fill up to the native adjacent cartilage depth quite nicely. Now, here's an example of another case. So this one is a little bit more complicated because it's the kind of patient you will all have seen a lot of. She was a patient, I think in her 30s, who's had patellofemoral symptoms since she was a child. So you've all seen that. You know they have maltracking, they have increased TTTG, they have patella alta. It's a pretty common injury pattern or degenerative disease pattern. And so she had patella alta, increased TTTG, and so that's why this incision is so big. So here, we've actually already done the tibial tubercle osteotomy. It's been lifted up, and it's actually wrapped in here, and we're going to distalize it and anteromedialize it. But while we've done that, we've got this defect prepared, and we're about to prepare this one. This is the after photo, so you can see those two lesions have had the MACI implanted in there. The reason I show you that is because it changes the rehab depending on what type of defect we're dealing with. So you'll have there, I see you have the handouts. There's some simple ones, there's some more complicated ones. There's actually a huge manual as well. It depends how in-depth you want to go. But we'll just highlight some key points. So this is an example of a patellofemoral patient, and this is how you would interpret this slide. This is for the first 3 months only, and what you see is that on the left-hand side there's rows for a single defect or multiple defects, and that affects how you progress them. So, for example, if you have a single defect, they can weight bear immediately. They can weight bear immediately with multiple defects in the patellofemoral joint too. In the tibiofemoral compartment, it's slightly different. If they have a single lesion, so patella only, for example, then they can put their pretty much full weight on there immediately, but we would have them locked out in extension when they're weight bearing. When they're non-weight bearing, they can start to range the knee, which they can do immediately. And actually, we recommend CPM, continuous passive motion, which seems to have kind of gone out of fashion for other areas of physical therapy. But for MACI, it's actually very much encouraged because we want to have joint motion, because obviously that helps with nutrition of new cartilage with the synovial fluid. But also, the new cells need some mechanical stimulus to help them to mature. And if we were to do that under normal joint loading parameters, that might be too much load. So CPM is a really good way to kind of offload it, but get that range of motion and the mechanical stimulation it needs. So I'm not going to go through it in too much detail because you can obviously read the information there, but you see that there's differences in progression of range of motion and weight bearing, etc., based on whether it's a single or multiple defect. And then similarly for tibiofemoral joint, again, I'm not going to go through it all because you can quite easily read it in your own time, but basically for the tibiofemoral joint, we're a little bit more restrictive. Obviously, when the patellofemoral joint is, or rather when the knee is locked in extension, there's not a lot of loading going on in the patellofemoral joint, whereas obviously in the tibiofemoral joint there is, even with the knee locked in extension, and that's the reason that we delay it a little bit here. Any questions about any of those things?
Which one is more common, single or multiple defects?
You know, I would say that single is much more common, but I deal with both of them on a regular basis. It just really depends on the individual and what stage of the disease they're at. Obviously, cartilage lesions are progressive, and you know, if you have a single defect and you leave it long enough, you're likely going to have multiple defects. So we see the full spectrum. So you're probably also wondering what the outcomes are, and you know, we already discussed a few reasons why you might pick MACI or osteochondral allograft over one or the other. But in terms of the actual outcomes of these two most common cartilage restoration procedures, the outcomes are quite similar, and they're good. So at 10 years of follow-up, both of them have very good rates of satisfaction. I would say that the overall evidence is probably slightly in favor of MACI. It has very good, reliable results to 10 years and a very low conversion rate to knee replacement. We already discussed some of the problems with osteochondral allografts, and of course we're also treating different pathologies. So you could argue that we might see a higher rate of conversion to knee replacement with osteochondral allograft because it's a bridge burning procedure, so it's kind of hard to revise it. And also we're likely dealing with more complicated pathology with bone defects, so that might explain some of it. But in general terms, MACI seems to have the most reliable long-term outcomes, but again, there's some nuance in there because of the different pathologies that might be treated. Most of the rest of the stuff on this slide is things that we've covered before, so I won't go over that. Anyone got questions about cartilage repair? Otherwise, we're going to change tack and talk about some other aspects of knee surgery. All right. So one of the other things I do a lot of is ACL reconstructions. So there's nobody very old in the room here, but you probably know some of the history of ACL surgery and rehab. One of the big changes is that, unlike in the 1960s to 1980s, we no longer splint patients in full extension after surgery, which is what they used to do then. And you can imagine if you did it now, it would be disastrous, and you'd never kind of dream of doing that, but that's what they did historically. And so, unsurprisingly, people had high rates of arthritis and stiffness-related complications. So just like there's been major changes in physical therapy, there's been major changes in surgery too. Lots of trends like, you're probably all familiar that we've moved away from transtibial drilling, we've kind of moved away from double bundle reconstructions. But despite all of those things, which have resulted in improvements in some areas, our rate of failure of ACL grafts has remained pretty much unchanged until recently. I'm going to show you an example of a case a patient that I treated recently. So 35-year-old ex-volleyball player, she came to me with this CT scan and an unstable knee. So I don't know how well these project at the back, but I'm sure that you can see that there's a huge defect here on the femur and also on the tibia. So she had had 5 previous ACL surgeries before she came to see me, and now she's got this situation where she's got a huge defect on both sides. So the defect in itself is not something that's necessarily too challenging to deal with, but it does mean that she probably needs 2 stages to deal with it. So that's another 2 surgeries, and she's already had 5 or 6, so that's kind of a big deal. So the way in which we deal with this is simply to bone graft it. There's lots of different ways of doing it. This is actually her surgery when I bone grafted it. And what we do is we actually make the tunnels a little bit bigger by reaming them out just slightly. That helps us to make them circular, but it also helps to remove debris from the previous surgery. And then this looks like a screw going in. It's actually shaped like a screw, but it's actually an allograft bone. And we screw that in there, and it usually integrates very nicely within 6 months. And you can see that we've done that on the femur and the tibia, and we fill those tunnels. Sometimes we need to add in additional material as well to fill the defect depending on the shape. But for her, these screws fill the gap nicely. But that wasn't her only problem. So this is her preoperative X-ray imaging, and there's a little dog here in the corner to give you a clue as to the point I'm trying to make. Does anyone know what the point I'm trying to make is with the little dog? No? Anyone have a dog who's got an ACL injury or had an ACL injury? No? You do? How were they treated?
We crated her for a long time and just let her rest.
Okay.
As much as she could.
Okay. Why didn't she have an ACL reconstruction?
She was too old.
Oh, she was too old. Okay. Well, another reason perhaps that she didn't have an ACL reconstruction is that in general terms, dogs don't have ACL reconstructions because they don't work. And the reason they don't work is because dogs have a very steep tibial slope. So this patient also has a steep tibial slope. And so you can see that in the middle image here. And what I want you to imagine is that that's a hill. And so if you have a bowling ball, it's going to roll down the hill. And so in that situation, the opposite analogy of that is that you're going to get anterior tibial translation as a result of this steep tibial slope. And that's going to put stress on the ACL graft, and it's going to fail, and that's why she's had so many failed surgeries. So the cutoff for this is about 12 degrees. So if you have a tibial slope greater than 12 degrees, which dogs have a lot more, but in humans, if you have 12 degrees, your risk of graft failure is 5 times higher than if you don't have that. So what we did for her was we did a CT scan of her knee, and we actually got a 3D printed model and cutting guide, and we very precisely measured her slope, and we planned a correction, and we did an osteotomy, and this is what it looks like. So you can see the before and after. So you can see before she was at 12 degrees, and afterwards she's at about 8 degrees of slope. We don't want to make it completely flat. If we make it completely flat, then we're going to stress the PCL. She could get PCL rupture, so there's got to be a balance. So we've bone grafted her, and then we put in this osteotomy to correct her slope, and then we did a new ACL reconstruction, and she's doing great now. But the question is, she had 6 surgeries, following a primary ACL injury. Could we have avoided this? And the answer is probably yes, we could have. So we have to think, what could we have done differently? And one of the things is something called a lateral extra-articular procedure. Is anyone familiar with that term? No one? Okay. So the way I explain it to patients is that we all drive one-handed all the time, but you'd never dream of holding the steering wheel in the middle. The reason is if you try on the way home, but I don't accept any liability, but you'll see it's very hard to control rotation because you're close to the center of rotation, yet that's what we're asking the ACL to do. However, if you hold the steering wheel lightly on the edge, you have really great control and you don't need to use much force. And that's the concept behind a lateral extra-articular procedure. It's something we add on the outside part of the knee to help share load with the ACL graft and restore more normal knee kinematics. So what that means is that when you have a combined ACL injury with an anterolateral injury, which is about 70 to 90% of acute ACL injured knees, if you only do an ACL reconstruction, those patients are going to have persistent abnormal knee kinematics. Now, you might not be able to pick that up, and most likely you won't pick it up with just doing a pivot shift in the office. But if we look at it biomechanically in the lab, then yes, they have persistent deficits, and that's going to put strain on your ACL graft, strain on your meniscus repair, and predispose to failure of those things. So this is how we do those procedures. There's 2 common procedures that we do for this, and it really depends on graft choice. On the left-hand side, we have an ALL reconstruction, and that's where we use a little piece of gracilis, especially if we're doing a hamstring tendon ACL reconstruction. We don't need to harvest any additional graft, and we use that to recreate the normal anatomy of the anterolateral ligament. So that's a structure that normally lies exactly in this area that overlaps the lateral collateral ligament, and we're just recreating that anatomically. The alternative is this procedure here called the modified Lemaire, where we actually take a strip of the middle of the iliotibial band and we route it underneath the lateral collateral ligament and fix it there. And that essentially does the same thing. So you're probably already thinking, well, how does that change the rehabilitation? It doesn't change the rehabilitation at all. I won't play the audio on this, but this is one of my patients who is back to pivoting sports at 4 months after ACL reconstruction. I didn't recommend that. In fact, I specifically recommend against that so early, but it just goes to show that adding in this additional procedure didn't cause any additional pain or delay his rehabilitation. Now, that's obviously just one patient, but on the left-hand side, you'll see that we've actually studied this in a matched pair analysis, and we demonstrated that there's no delay in functional recovery after adding in this additional procedure compared to an isolated ACL reconstruction. So we've just recently completed our randomized control study looking at this. We've compared about 300 patients in each group. We compared an isolated ACL reconstruction with a BTB graft, which is theoretically the gold standard. I'm not sure I agree with that. Maybe we can discuss that afterwards. But in general terms, lots of surgeons believe that if you have a high-risk young pivoting sport athlete, that BTB grafts are the best. And so that's why we picked that as our control. And then we've compared it to hamstring tendon ACL reconstruction with an anterolateral ligament reconstruction. So this is how we do that procedure. So we harvest the hamstrings and so that's the semitendinosus and the gracilis. We triple the semitendinosus and we add the additional strand of gracilis to that, and that gives us a 4-strand construct here for the ACL part of the graft. So it's a nice big diameter graft. Then we have this additional length of gracilis, which we shuttle deep to the iliotibial band through a tibial tunnel, and then we fix it back to itself here. So it's very minimally invasive. This is just through tiny stab incisions, no additional large incisions needed. This is the main result from our study. So at a minimum follow-up of 5 years, and that's important to note because most of the ACL studies that you read in the literature only have 2 years of follow-up. And actually, you should always read those with some skepticism because that's not long enough. And we know that because many patients don't even get back to sport by 18 months. So 2 years really isn't long enough to evaluate graft failure. But when you look at those 2-year follow-ups, they all typically have very low graft rupture rates. So we need to look at longer term. And so in this study, in our isolated BTB graft group, which is theoretically the gold standard, the failure rate at 5 years was 10%, but only 4% in our combined reconstructions. In terms of problems and knee stability, there was no difference between groups. There were significant differences between the groups with respect to other reasons for reoperation. So obviously graft rupture is the main one, but there was also reoperation for Cyclops syndrome. So Cyclops syndrome, I'm sure you've all seen Cyclops syndrome? No? Okay, so Cyclops syndrome is where patients have an extension deficit after their ACL surgery, which I'm sure you've all seen, but that extension deficit doesn't go away. And typically what happens is that when the knee is unable to go into full extension, especially in the early postoperative period, you have some hematoma in the knee, and that collects in the notch. If your knee goes fully straight, it kind of dissipates out of the notch, but when it stays in the notch, it forms scar tissue, and that becomes a Cyclops lesion, and that becomes a permanent block to extension, and most often we need to go back in there and remove it. Now, this is well recognized to be more common with BTB grafts because they tend to cause more stiffness-related complications, and so that's what we found in this study too, that there was a much higher rate of reoperation for Cyclops syndrome. We also find a much higher rate of secondary meniscectomy in the isolated group, and that's again from what I mentioned previously, because when you add in the additional ALL reconstruction, you've got better knee stability, and so we're protecting that repair. We actually demonstrated that in another study. So we looked at about 400 patients who underwent medial meniscus repair at the time of ACL reconstruction. And what we found was that in those who had an ALL reconstruction, the secondary meniscectomy rate was 2-fold lower than those who didn't have an ALL reconstruction. So their meniscus repairs failed twice as often because the knee just wasn't as stable. Now, I was lucky enough to be involved with this study of the French national ski team, and alpine skiing is a really interesting sport from the ACL perspective. Does anyone do that sport here? No? Arizona's not ideal for it, but it's interesting from an ACL perspective because every study since the 1980s has shown a graft rupture rate of about 30%. It's just a very, very high-risk sport. Lots of attempts have been made to reduce that risk. So in 2012, the International Ski Federation changed the rules. They changed the length of the skis, the curvature of the skis. They even changed the rules the course designers were allowed to have to try and make things safer. But none of those things made a difference. But you can see that our study is the only study since the 1980s that demonstrated that when we add in this additional procedure on the outside part of the knee, we significantly reduce the graft rupture rate. And this is in our elite athletes, so it's really a true test of what we're doing. We also have long-term data, so we have data out to 10 years, and again, the same findings. So at 10 years, isolated ACL reconstruction, 17%. That's kind of a good figure to remember. So when you're talking to patients, if they're asking, how's this going to pan out for me in 10 years, you're obviously going to tell them that they're probably going to have a bit of arthritis, but you can also tell them that, probably a 17% chance that their ACL reconstruction will have failed, unless they have an ALL reconstruction as well, in which case the graft rupture rate is very, very low at 10 years. We recently had a consensus group meeting with almost 60 surgeons from around the world kind of discussing this particular topic, and we had some really great consensus. I'm not going to go over all the details with you, apart from to say that there was broad, widespread agreement on the indications for when to add this procedure. So this is a key slide, and our indications are basically patients. The overall summary of this is people who you consider or who have been proven to be at high risk of a graft rupture. So that's our young active patients, skeletally immature patients specifically. If they have a high-grade pivot shift or Lachman, we all recognize those to be high-risk patients. If they're having a revision ACL reconstruction, those with hyperextension, chronic injury, planned return to pivoting sports, previous contralateral ACL injury, especially if that previous contralateral ACL failed. I mean, for sure that they're a high-risk patient, and then tibial slope. So those are all reasons. If you see patients in those categories, you should be thinking, well, this patient needs to have an additional ALL reconstruction as well. I'm going to change topic again. How are we doing for time? What time do you guys need to get back to?
We have you scheduled till 1 o'clock.
Okay. All right. We'll keep going with, we have a whole bunch of more stuff. So ramp lesions, anyone familiar with this concept? No? This is a really important concept. So ramp lesions are meniscus tears, and the reason they're important is because they have important biomechanical consequences on the knee. If we miss them, it causes some big problems, which we'll discuss in a second. And also, they're easily missed. And one of the reasons they're easily missed is because not everybody knows about them, as we saw here. But the other reason they're easily missed is because the standard arthroscopic techniques, so what surgeons do, can also miss it, and I'll show you what we do additional to find them. And also, they're easily missed on MRI for various technical reasons, which we'll also show you. But the main reason these injuries occur is because when you have an ACL injury, the semimembranosus fires violently, and if you remember, there's an arm of semimembranosus that connects to the posterior horn of the medial meniscus. It pulls on there, and it basically creates this tear, which is at the meniscocapsular junction. So here's the capsule at the back, and this is the posterior horn of the meniscus, and we've got a tear there. Here's an example of an acute one where we can actually see the arm of semimembranosus right there. So the first thing, in order to minimize the risk of missing the diagnosis, is to have an appropriate index of suspicion. So in this series of 3,000 ACL reconstructions, we found that 25% of ACL injured knees have a ramp lesion. So it's 1 in 4 patients. So you should definitely be aware of it and definitely be thinking about it. These are the risk factors we identified: male, gender, patients aged less than 30. So you're probably already thinking, well, that's not so helpful because that's a lot of patients. So the main one to pick up on this slide is the preoperative side-to-side laxity greater than 6 millimeters. So if they have a strongly positive Lachman, which you guys can easily do when you evaluate them, that strongly suggests and is until otherwise proven a ramp lesion. Here's an example of how it looks on MRI. You guys are all allowed to order MRIs now. Are you doing that or not so much?
Haven't yet.
No?
I did ask about it. I feel like we haven't gone through the procedure of how to kind of establish that. I think insurance is the barriers too.
Oh, okay.
Meaning like they need a doctor to order the imaging for them to cover it versus just physical therapists. So
Well, I think Governor Hobbs has given you permission to order imaging, but I don't know about the ground level technicalities. But for sure, there are other physical therapists ordering it. So if it was something you were interested in, you could definitely reach out to the imaging companies. And I know that they're providing education on how physical therapists should order them. So that could be something to explore. But anyway. Let's get back to the actual pictures here. So this is what a ramp lesion would look like on an MRI. So this is the posterior horn of the meniscus, this is the capsule, and this high signal vertically oriented line, that's the ramp lesion. Now, when we do an MRI, the knee's usually in extension, and so that gap can actually be shut down because the medial meniscus translates during knee motion, and in this position, that gap's often closed. So that's why this lesion can be frequently missed. Here's an example of one where the knee's bent, and you can see how that gap's really opened up and how it could easily be missed with the knee in extension. So this is how it's missed by surgeons too. So most surgeons will do anterior compartment viewing. If you've been in the OR, this is what you'll have seen. You look inside the knee from the front, but what I do is I look in the back of the knee, so we actually put the scope through the notch, which I'm going to show you how we do in a second, and we put a needle in there and we probe the meniscus. And if we do that, we find an additional 40% of tears that would otherwise have been missed. Here's an example of that. So here's that standard anterior viewing, which you'll all have seen in the OR. There's a probe coming here, pulling on the meniscus, and it looks totally normal. There's nothing abnormal going on there. I put my scope here in between the femoral condyle and the PCL into this gap, and this is the view we have. So this is exactly the same knee. This is the capsule, and you can see here that we've got a ramp lesion. It's a tear at the meniscocapsular junction, which would have been missed if we only viewed here. Here's an example of a more subtle one. Again, we've got the probe pulling on the meniscus, it looks totally normal. We look in the back of the knee, and here we're probing with a needle. We don't see an obvious tear, but these fibers are redundant. Nothing in the knee should be loose like that. And so if we put a shaver on there and shave away these loose fibers up here, you can see that there was a tear hiding underneath. So again, if the surgeon's not doing all these steps, you're going to miss the ramp lesion. It's important. If you miss it, and you don't fix it, and you just do an ACL reconstruction, you can see from this slide that you have persistent internal and external rotation deficits, which are obviously going to stress your ACL graft. What if you leave it? So this is a study that looked at 20-year follow-up of ramp lesions that were not treated. They did an ACL reconstruction, they said there's a ramp lesion, we're not going to do anything about it. What they found was that almost 30% of people had progression of that ramp lesion, and it became a bucket handle tear, which, as you know, has serious biomechanical consequences for the knee and is going to predispose that patient to arthritis, especially in an older patient where probably they're not going to have fixation of that bucket handle lesion at long-term follow-up. But that's at 20 years. So what happens in the short term? So this study actually looked at 2 years follow-up, and what they found was that ramp lesions that were left untreated, or rather, let me phrase it a different way, of those people who developed a bucket handle tear in those 2 years after their ACL reconstruction, 70% of them were those that had a ramp lesion that was not treated. So these lesions progress. And you'll all have seen patients who've had an ACL reconstruction, their knee seems stable, and then suddenly they're having a secondary meniscectomy. That doesn't make sense, right? But this is part of the reason. Two things. One, they had a ramp lesion that was missed or wasn't fixed, and that tear's progressed. Or the other reason is they had an ACL reconstruction and they didn't do the extra-articular procedure, and the knee still got some subtle instability, which is stressing the meniscus. This is how we fix it. So we make a posteromedial portal, we shave, just like we do for preparing any tear to help the biology, and we use a little hook. We pass a suture through the posterior horn and the capsule, and basically put 2 or 3 sutures in, and that's pretty simple. That's how we do it. Here's a little video of that. I'm going to try and skip ahead here because we're running short on time. So here's making the portal. You can see there's an acute ramp lesion there. We just shave that to help with the biology. And then we put our suture hook in there. So that went through the capsule, meniscotibial ligament, and now the posterior horn of the meniscus. We pass our suture through there, tie some knots, and just repeat, typically 2 or 3 knots. I'm going to change tack again. Arthrogenic muscle inhibition. This is something you guys see all the time. The way I see it most frequently is in patients who've had ACL surgery, ACL injury, or even patients who've got chronic knee conditions like osteoarthritis. They'll present with quadriceps activation failure and an extension deficit. So we have a technique that we've demonstrated works pretty nicely to resolve this. So I'm just going to show you a video on that. But the basic principle is that, well, I'll show the video. So this is a patient who's got an acute ACL injury. You can see he's got an extension deficit and his VMO is not firing. So you guys see this pretty frequently. He's a good patient for this video because he's got a good, very nicely defined VMO on the opposite side. On this side, you can see his rectus femoris is contracting, but not his VMO. He's got good VMO contraction on the other side. So in simple terms, what's happening here is that the hamstrings are overactive and the quad is switched off. That's how I explain it to the patients. So we want to get that hamstring tired out so it doesn't fight the quad anymore. And I know this is a lot below your level, but this is the level at which I am explaining it to patients. And so we just do some resisted contraction exercises to fatigue that hamstring. And you'll see that within just a couple of reps, their knee is already going much straighter. And this is not spread out much, it's spread out by a minute or so. And then we flip them over and we do the quad activation exercises, which again, in the interest of time, we're going to skip over. But what we demonstrated was that in 80% of patients after an ACL injury, firstly, they have this problem and that we can solve it within just a few minutes of doing these exercises. The reason I'm interested in it is two things. One is any extension deficit is typically poorly tolerated. I'm sure you all have seen that. Even if it's 1 or 2 degrees, patients don't like it. It doesn't feel normal. And the other reason is the Cyclops syndrome. So if you have an extension deficit at 3 weeks after surgery, your risk of a reoperation for Cyclops syndrome is 2-fold increased. And if you have an extension deficit at 6 weeks, it's 8-fold increased. So I see all my own patients at 2 weeks and make sure that they've got full extension by doing this exercise. So next time you see someone with an extension deficit and quad activation failure, try this and let me know what you think. I'm going to skip over a few slides here. We've got a few more minutes, so let's talk about ACL repair as opposed to reconstruction. Anyone seen ACL repair patients? You have one right now? What kind of repair did they have? So that's a reconstruction, right? They used a patellar tendon graft. So I'm talking about repair, where we actually fix their torn ACL. So this is a really great case example of the advantages of that. So this was an Olympic athlete. She's a skier for the Slovakian team. She was training for the Olympic Games and she had a partial tear of her ACL 5 months before the Olympics. And she decided not to have surgery because it was a partial tear and also it was only 5 months away from the Olympics. So unfortunately in competition before the Olympics, ACL tore completely and she missed that games. So then she was preparing for the next one. And again, 5 months before, so like perfect case control study, she tore the other side. And she knew that if she had an ACL reconstruction, it was going to take her a year to get back because that's what her previous experience was. So she actually underwent an ACL repair and these are her pictures. So you can see that she had a femoral avulsion. And you're going to see skiers in the ski season here from Flagstaff and wherever else. And if you look at their MRIs, you'll see that a lot of them have proximal avulsions. So they are candidates for an ACL repair. Whereas a young soccer and football players, their ACL is usually mid-substance tear and it's usually kind of exploded and not amenable to repair. But skiers have a different injury mechanism and their tears are. So that's what she had. And so basically we fixed that back. So this is actually her intraoperative repaired ACL. It looks like a normal ACL. What we demonstrate, well, she actually got back to the Olympic Games, 5 months after she came 17th. So her recovery was just super quick. And that's what we see in our recreational athletes also. So this is 60 in each group, ACL reconstruction versus repair. These are all recreational athletes, no pros. And you see that at 6 months, their isokinetic strength testing is way better than reconstruction. Their graft rupture rate, or rather their rupture rate, is very low, and over the age of about 20, it's comparable. So this is really something not for the very young patients. It's really, in my practice, it's for the skiers, particularly the older patients, those who may otherwise have had a cadaveric ACL if they have a proximal avulsion. But they don't get arthrogenic muscle inhibition. Their recovery is really quick. So if you go to my Instagram, you'll see a couple of patient testimonials. One of the really nice ones I have is a 65-year-old female. She was a skier, and she, at 3 weeks after the surgery, she called my office asking if she was allowed to run. And you can imagine that our 18-year-old soccer athletes are not doing that. So that's how good she felt. And when she came back at 6 weeks, she'd already hiked Black Mountain. If anyone knows it, it's a steep, strenuous hike in Cave Creek. So it just shows that the function is much improved and quicker. So we've got just a few minutes left, so I'm going to talk about a couple of other things. So I do just as much shoulder surgery as I do knee surgery. Anyone familiar with this implant? No. There's a new version of the American Academy guidelines for rotator cuff surgery that have just been released, and this is part of it. This is something called regeneration. It's a bioinductive implant. It's basically a patch derived from cows, collagen, and there's two main uses for it. One is if a patient's had a previous failed rotator cuff repair, or you consider them to be at high risk of failure, adding this patch is going to thicken up their rotator cuff, their native tissue, and it's going to reduce the risk of re-tear. That's been shown in many randomized controlled trials. But the reason I'm showing it today is because it's of particular benefit also in another group, which is partial tears. Now, most partial tears I don't even see because you all get them better, right? So I'm talking about the ones that fail non-operative treatment. So if they fail non-operative treatment, historically, from a surgical perspective, we've had two main options. One is to complete that tear and fix it back, which is always a bit disconcerting as a surgeon because I'm making the problem worse, and if it fails, then that's not great. Luckily, the failure rate is very low for that particular type of tear, but it can still happen. The other traditional treatment is to do an in situ repair where we make small holes in the tendon and fix it back. But that's often associated with increased pain and stiffness for the first few months. It's not an easy recovery, so that's not a great option either. This is a good option because it's a very quick surgery. It takes like 10 minutes. We just go in there, and regardless of whether the tear is on the articular side or the bursal side, we just put this patch on the bursal side, and it basically solves the problem by thickening up the rotator cuff, and it can even allow some healing of the native tissue. So here's an example of a case. So you can see this is an older patient. They have a little bit of chondromalacia up here. This is the supraspinatus. This is some fibers hanging on, and this red area is all footprint where it should be full of rotator cuff, but it's torn off. It's all retracted up here. This is the biceps tendon. So in this patient, I did a biceps tenodesis, and the only other thing I did was I went into the subacromial space and I put this patch on top. At 2 weeks, they're out of the sling, which is a big advantage. We're not drilling holes in the bone, we're not passing sutures through the cuff, so they don't need that period of immobilization that they would have needed with a traditional style repair. So they're only in a sling for 2 weeks, and they start strengthening pretty much straight away. The other big advantage is that they tend to have very early good pain relief as opposed to a typical cuff repair where there's quite a lot of variation. Some people have excellent early pain relief, but others really struggle to get that until 6 to 8 weeks out. So it's a good option. I'll just show you a couple of other things. We've got 2 minutes left, basically. Anyone familiar with this implant? This is another. You've seen one?
We have one right now.
You have one right now? How are they doing?
Not good.
Not good? No. Yeah. And what was the indication for this procedure?
I think he had a full supraspinatus tear.
Okay.
And infra as well. And
Yeah.
they were both retracted.
And did you see him before surgery?
A little bit.
And how was his shoulder before surgery? In terms of his range of motion, did he have good range of motion? Did he have pseudoparalysis?
No, I think he was sitting at like 110-ish, pushing.
Okay. So that's why he didn't do well from this surgery. So for those of you who don't know, this is called the in-space balloon. It's really for massive irreparable posterior-superior rotator cuff tears. So as you know, what happens is you have superior migration of the humeral head, and so deltoid doesn't work, or doesn't work as well, and also they have pain from impingement of the humeral head and the acromion. So all we do is we go in the subacromial space and we inflate this balloon, which recenters the humeral head, so that helps you guys to rehab deltoid and get whatever cuff's intact, more functional. And it also helps with pain because it stops that impingement with the acromion. But there's very specific indications for this procedure. So they have to have an intact or repairable subscap. They can't have arthritis, and they have to have good range of motion. They can't have poor range of motion preoperatively. If they do, it's not going to work. And so you can imagine the number of patients who meet that criteria are quite small, but there's some good advantages to this because it's very minimally invasive and quick compared to, for example, another good option for this situation, which would be, for example, a reverse shoulder replacement or a lower trapezius transfer or superior capsule reconstruction. Those are all options, but and they all have pros and cons. None of them are perfect. For example, if you have a 50-year-old who's in this situation, doing a reverse is not a good idea. It's going to fail, and then they're going to need a revision, which, hip and knee revisions are not such a big deal these days, but shoulder replacement is, because the socket's only this big. If you have bone loss, that's a big problem. So this particular procedure is really good for patients who've got lots of comorbidities. So the most recent one I did was someone who was 85 years old, I think. He tried all the non-operative treatment. He had some cardiac problems, so he was not good for a general anesthetic. So we actually did his surgery awake. He just had an interscalene block, but he was able to watch his surgery. We did a 10-minute surgery. We put this balloon in the subacromial space, inflated it, and he did really great. He had immediate pain relief and good range of motion. But patient selection is the key to success with this procedure.
Can I ask you what's next step if this fails?
Yeah, so it depends. So my 85-year-old, if it fails in them, you know, they're not really a candidate for a surgery, so it would be pain management. In a patient who doesn't have such severe comorbidities, there's loads of options. So, for example, you could do a lower trapezius transfer, which is probably one of the my kind of go-to for this kind of thing right now. You know, we did lots of superior capsule reconstruction in the past, and the results are not necessarily that reliable. Some people do great, other people not so much. But lower trapezius transfer seems to be a really good option for this. The other option is reverse shoulder replacement.
I think they tried the lower trap one on him already.
Right. Yeah, so it sounds like he's heading towards a reverse then, your patient. And then I'm just going to show you one last thing. So I'm sure you've seen people who've had allograft reconstructions of their rotator cuff, human allograft put in there. No? Some of you have. So basically for complicated tears, revision situations, or where patients have a high risk of failure, we want to augment that, especially if they've had a failed previous repair. If you just go and re-repair it, you know, it doesn't make sense because it failed the first time when you probably did a good job. And now if you're going to do the same thing, you know, the rate limiting steps their biology. So you got to do something different. So the most common way to treat that is with a human dermal allograft, which is basically a piece of skin from the back. It's nice and thick. It's from someone who's passed away, so we're not harvesting anyone's back skin to do this. But it's expensive, it's difficult to handle, it's biologically kind of inert, it's a scaffold, it doesn't have its own kind of biological activity. So this is an alternative. So in this picture, what you're seeing is an open subpectoral biceps tenodesis. So normally we discard this piece of tendon after we've removed it, but here what we're doing is we're actually squashing it in a press and making a patch. And then we implant that patch. So this is a patient who's had a revision rotator cuff repair, which is hiding underneath here, but this is the patch that we put on top. So that adds some structural support to the repair, and it also adds the patient's own native biology with viable live cells in there. So it's just an alternative, but it's cheaper, it's more biologic, so it's a good option. So I like to have great communication with all the physical therapists I work with. So there's my personal phone number. If you want to jot that down, feel free to reach out to me anytime. And I'm also happy to answer any questions.
For the ramp lesion that you were talking about earlier, will our special test pick that up?
There is a special test, but not specifically for ramp lesions, but that special test is your Lachman or side-to-side AP laxity difference. And if it's above 6 millimeters, then they basically have a ramp lesion unless proven otherwise. Yeah. Any other questions?
Considering referral, I guess what's the best? I mean, is it just contact?
Yeah, my email address is there too, so you could email it to there. You can fax it to my office. You know, if it's HIPAA compliant communication, you can just text to me.
How many MACI procedures do you do in a year?
It's not a huge number. I don't think anyone in Arizona is doing a huge number. I would say it's less than 10. Yeah.
And then with your the ACL with the ALL, is that common practice now, or is that where it's moving to?
I would say that based on the consensus meeting that we had last year, most knee surgeons are in agreement that this is a good thing, and that the recommendations we came to were in agreement through all of us. And I maybe I didn't go into it in much detail, but they were surgeons not just from the US, but globally. And so this is kind of something that's now globally agreed. But not every surgeon is doing this, just like not every surgeon is doing, you know, even today, you're going to see a lot of patients still having meniscectomy, whereas maybe they should be having a meniscus repair. So I think that if you have an ACL patient, and especially if you think they have a risk factor for re-tear, you should find someone to refer them to who actually does this.
Oh, another question, sorry, the Cyclops one?
Yeah.
Is that something we can pick out as well, or we just know like, they lack an extension, it's been a while, send it to you guys?
Yeah, so it's a very good question. So if you see someone who is, 2 weeks after an ACL reconstruction, they don't have a Cyclops syndrome, it's possible, but it would be very rare because most surgeons would check at the end of surgery that the knee is going fully straight, and we take special steps to make sure there's nothing impinging at the time of surgery. It's possible though, but most likely not. So if you have someone who's got an extension deficit at 2 weeks after an ACL surgery, that's arthrogenic muscle inhibition basically until proven otherwise. And so you would do the steps I showed for arthrogenic muscle inhibition, and I'm sure you have your own stuff that you like to do, so you would do all that stuff. But we start to worry about Cyclops at around 2 to 3 months out from the surgery. If they still have an extension deficit at that stage that hasn't resolved, we probably want to get an MRI and look for a Cyclops syndrome.
So is the Cyclops syndrome something that's already there beforehand, or is it something that develops after the procedure?
Yeah, so it develops afterwards. So that was my point about if they're 2 weeks post-op, they're not going to have a Cyclops syndrome because it's something that develops over time. And again, the reason it develops, there's lots of different theories, but one of them is that, after a surgery, we have hematoma in the knee. And if the knee is not going fully straight because of arthrogenic muscle inhibition, that hematoma stays in the notch. Whereas for those patients who are able to fully extend their knee, it kind of gets pushed out and it doesn't form a nodule of scar tissue there. So that scar tissue, there's lots of serial MRI studies that look at patients who go on to develop a Cyclops syndrome, and they showed that at day 1 post-op there isn't a Cyclops, but it kind of slowly develops over time, and that's why we believe it's due to the hematoma in the notch.
Gotcha.
Yeah.
Thank you.
Sure.
So would you anticipate that for like even a total knee, or no, because of where?
The Cyclops syndrome isn't really so much of a thing with total knee because, because you have an implant in the notch. However, total knee patients can get arthrogenic muscle inhibition, which you'll have seen, and so the exercises I showed you would still be useful there. And one of the things I didn't mention was that we published a systematic review looking at all the different modalities used to address this problem, and there's only 2 that have good evidence behind them. You'll be pleased to know that one of them is physical therapy, which is basically the exercises that I showed, but the other one is cryotherapy. And that makes sense from the kind of perspective that, that helps with swelling reduction, which is kind of obvious, but what's not so obvious is that it also has an immediate effect. So if you have a patient who has a refractory or difficult to manage AMI, I would recommend that you ice the knee 10 minutes before you do physical therapy, because it has an immediate effect on how the knee communicates with the brain and spinal cord in a favorable way, and it actually reverses the effect of AMI immediately. It's not going to obliterate, the problem completely, but it helps to address it. So it's twofold.
I feel like we stay away from that because you're like, I don't want anything to stiffen up with the cold. So
Yeah.
But that makes sense, kind of what you're saying.
Yeah, and it's evidence-based, not just me saying it. But try it next time you have someone with this
I have
issue.
a couple of people, like my ACL guy right now, and I can tell, and I feel like in my head it makes sense because if I'm sitting here and I can tell they're basically guarding, right? It's
Yeah,
it's
exactly.
the same thing, right? And so like obviously, and I don't sit here and push into it because it's counterintuitive, but like I don't know why I didn't necessarily go to like let me find a way to turn off that hamstring
Yeah.
and actually get more mobility.
When are you seeing them next?
Tomorrow.
Okay, I'm going to email you the video,
Yeah.
and then you can just do it with them. And actually, in addition to the video, that video is kind of patient-oriented. We have a couple of more detailed videos that go through a lot of the evidence and stuff, which I'll share with you guys as well. If someone can send me an email address, and then you guys can share it amongst yourself.
Yeah, I'll send it to you.
Thank you.
Yeah, my pleasure.
So you're icing the hamstring?
No, the knee. The knee, yeah. Because the problem is driven from the knee. As you know, the knee, the brain, and the spinal cord are communicating all the time, and the primary drivers of AMI are pain and swelling. And so, obviously, icing has some benefit in the long term in swelling, but it's also got this immediate benefit as well. Any other questions?
Yeah, I have a question. But for a MACI procedure, when you refer for therapy, is that something you provide, like especially with the nuances
Absolutely. Yeah, it's complicated, and I have to go through the the manual myself when I refer a patient. But we don't always necessarily stick to exactly what's in there for various reasons. But those various reasons can include things like doing concomitant procedures. For example, if we're doing a tibial tubercle osteotomy or something, that's going to be the rate limiting step. And another reason is that sometimes the range of motion that they set is quite restrictive. And one of the reasons they restrict it is because we don't want too much shear forces, especially in the patellofemoral joint. But it depends where the lesion is, and some lesions engage later rather than sooner. And in those patients, we can actually speed up their progression of range of motion a little bit. So it's kind of individualized. But for every patient that I refer post-operatively, I provide a rehab protocol, whether it's MACI or anything else.
And are there like typical markers or things that you want us to be aware of, like along the process of therapy, to like alert you if something's not, or is it just any of those stages not meeting ends, or?
Yeah, so that's part of the reason I give every physical therapist my number, because I want to know if there's any problems. And that can range from just you having a concern, I'm happy to discuss and be available, or if there's a specific problem. And specific problems would be, if the patient has unexpected pain, stiffness, concerns about wound healing, if they're having mechanical symptoms, for example, after a MACI, sometimes that can indicate overgrowth. And obviously, if you don't have if you have not seen necessarily a lot of MACI patients, you might not know whether, what's the right time to kind of refer them back or let me know. So that's why I'm happy to always be available. You can just send a message and we can chat about it. It's not a big deal. I'd rather know sooner rather than later if there's any concerns.
And then for therapists who have, is there anything that they've done in the past that you really appreciated along that rehab process, whether it's for MACI or any other referrals?
For sure. I work with loads of good physical therapists, and but I think the best thing is communication. And the reason it's important is, firstly, if I don't know there's a problem, then we can't work together to fix it. The other reason is, which is more common, because fortunately in sports medicine we don't have a huge amount of complications. So the other most common reason I find it valuable is that patients realize, or they're aware usually, that we're communicating about their care. And that has a really strong influence on their perception of the care they receive. And they realize that we actually really care about them. And, I don't know if placebo is the right term or not, but there's definitely a therapeutic benefit to that. And I think that they do better, they're more confident in the care they're receiving, and that is really important. And it's even more important when a problem arises. If you have a problem and there's good communication between us all, then that's a good way to not only solve the problem but to avoid more complaints or problems in that regard. So I think communication is the number one thing. Any other questions?
That's fantastic.
Thank you. Appreciate it.
Great, appreciate it.
Thank you. Well, thanks all for your time. I appreciate it.